So it is just a huge, huge honor to be sitting here in Melbourne, Australia with my idol and mentor for probably 30 years, Geoffrey Knight. How are you doing?
Terrific, Hart.
Geoffrey Knight has a BDS, a dental degree, a Master's in Science, MSc, an MBA, and a PhD. He is, without a doubt, the most famous dentist in Australia, and I'd say Graham Millicich is probably the most famous dentist in New Zealand.
That's a broad brush.
No. I mean, how many times have I lectured in Australia since 1990?
Half a dozen?
Yeah, I've come down here.
Right.
I think this is the 6th or 7th time I've been down here. So I have breakfast, lunch, and dinner with these guys. They idolize you. I mean, and you've been doing this for a long time.
I have been doing it for
and
a while.
How many countries have you lectured in?
I haven't counted, but there's a few.
Geoffrey Knight is a general dentist and internationally noted dental speaker from Melbourne, Australia, which is where we're at now, with special interest in minimally intervention aesthetic dentistry. He has pioneered protocols for the pharmacological management of dental caries and periodontal disease. He has introduced the concept of tunnel restorations and co-curing to minimally invasive dentistry and developed a number of innovative aesthetic techniques for the placement of direct laminate veneers, direct resin bridges, and occlusal rehabilitation using composite resins. He has consulted widely across the dental industry and is named on several patents. He is currently working with SDI, which is the largest dental company in Australia.
That's correct, yeah.
And the largest manufacturer of amalgam, too, aren't they?
Yep.
Yeah. And PDS, what's PDS?
Well, it's the professional dentist supplies. That's what Paul is involved with.
That's with Paula.
Yeah.
Well, come into the camera and say hi. Paulette is
dental hygienist.
A dental hygienist. I don't have anybody in front of me. And what is the name of your company?
So I work with Geoff Professional Dentist Supplies as a business development manager, and I also have my own teeth whitening and dental hygiene studio on the Mornington Peninsula. So 2 hats on, which is exciting.
Well, we're going to do a separate podcast with you, but if you want to sit here and join us...
I'm going to sneak back over there and Geoff can be the star.
Are you sure? Because you'll make us look so much better if there's one good-looking one of the three of us. Apart from his broad clinical base, he has been state president of his dental association and has extensive political and economic experience within the profession. He has been published in Quintessent International, Australian Dental Journal, and Journal of Periodontal Research. He has produced a series of clinical videos and written numerous articles on aesthetic and adhesive dentistry that have been translated and published internationally in a number of languages. His recreational pursuits include mountaineering, which I climbed the tallest mountain in Africa, Kilimanjaro. And the last time I lectured down here, I said, Geoff, I want to climb the tallest mountain in Australia, Mount Kosciuszko.
Mount Kosciuszko, yeah.
A Polish name, right?
That's right.
And that was so much fun. Thanks for taking me out. I got
that was a lot of fun.
I have 2 of the 7 continents down. His recreational pursuits include mountaineering, an interest that has taken him to some of the highest peaks on several continents. You should hear the stories of when he climbed the highest peak on Antarctica. Ryan, we got to do that. I think my next one I want to do is either Russia or Antarctica.
Yeah.
And I'm going to save Everest until I'm cremated in a bar of ashes.
Yeah,
and I'm going to have Ryan carry me up there.
Do it on a helicopter.
And disclosure, Geoff Knight is a technical consultant for SDI, which is a Strategic Defense Initiative. That's Star Wars.
That's right.
Ronald Reagan shooting down missiles with his lasers. And receives a royalty from the sale of Rebastar. And, okay. So, guys, there's so many things we could talk about. What are you most passionate about today? Caries.
Well, it's the change. Look, it's the change that's happening in dentistry. I was at IDS this year, and it's probably the biggest dental trade display in the world. And I think you can't get round in a day. And I think that about 75% of IDS was dedicated towards high-tech traditional dentistry, which means that there was CAD/CAM, there was 3D printing, there was all sorts of radiological techniques of imaging, and this sort of, the surprising thing here is the whole thing is based on the concept that the ongoing proliferation of tooth decay and the loss of teeth. And so the whole dental industry is pushing in that direction. And it's really, and okay, that's fine, but if we the model we have for restoring teeth these days means we have to remove the caries. I mean, most dental schools now say you can leave the sort of affected dentine, and that's or dentin, as you call it, I suppose, the affected dentin, which is the dentin
Affected with an A.
affected with an A. Yeah.
Affected.
Let me say dentine because I'm used to it. The affected dentine, which is a dentine that doesn't, the bacteria aren't in the dentinal tubules, but the fact is because they're releasing acid, they've sort of made the dentine soft. And traditionally we were taught to remove that. Now they say you can actually leave that dentine behind.
And what's that dentine called?
That's called the affected dentine.
Affected,
Then there's the infected dentine, and that's the dentine where the bacteria are actually in the dentinal tubules. And
Just
that's,
full disclosure, Australians say dentine and drive on the wrong side of the road, and Americans say dentin and drive on the right side of the road.
you know that the American pronunciation is the pure English, don't you?
Is pure English?
It's pure English, yeah, because when the Pilgrim Fathers came out to America, that's the way they spoke English. And so there was a faucet. Faucet's a very old English word. And then there was program, which is P-R-O-G-R-A-M, and we spell it P-R-O-G-R-A-N-E-E. And there was colour, C-O-L-O-R, which is, we call it couleur. And that's the French influence on the English language after the Pilgrim Fathers came out to America.
So which is English and which is French?
The Americans speak real English. The English speak a francophile version of the English because of their French influence on the English language. The Brits don't like to hear that, I might say.
So what's there's some say aesthetic dentistry and some say aesthetic.
Yeah, well, see, aesthetic is a French
E-S-T-H is French.
A-E-S-T-H, but E-S-T-H is an English word. You see. So it's been.
So are you a hygienist or a hygienist?
Hygienist.
Hygienist. Hygienist.
See? So you go, but I'm
So
used to speaking a particular way.
So
It's too
you
hard
were
to
saying
change.
the infected dentine needs to be removed, but the affected
Well,
dentine.
they still say the infected dentine needs to be removed, you see, because that's even though they can't differentiate between the affected and the infected, they still say the affected can be left behind, the infected has to be removed.
Even though there's no way clinically we can tell the difference.
Differentiate. Well, it's a sort of colour, I suppose. There's a different colour. Okay. Now, however, if you believe that model, that means that basically that a tooth or the dentine pulp complex is the only tissue in the human body that doesn't have a front line defence against bacterial invasion. Now, just think about it. Because most tissues, when bacteria attack the body and try and get in, the body has a defence mechanism which is able to go ahead and actually sort of reduce the viability of the bacteria so the body can put a defensive barrier over it. For instance, if you've got a burn on scar tissue, now the scar tissue forms over that burn, that's not skin, but it's still keeping the bacteria out. Now, have you heard of arrested caries? Mm-hmm. Okay. Every dentist heard of arrested caries, and yet arrested caries is dental scar tissue.
Explain what arrested caries is.
Well, everyone's seen arrested caries. You'd usually find on the buccal segments of lower bicuspids or molars where there's been some sort of carious activity, and then the person changes their lifestyle and their diet, and that sort of soft carious dentine then hardens up as a black sort of surface, but you can't scratch it. Okay, it's quite hard. And that's keeping the bacteria out. And that's because what happens is that the body is able to sort of overcome the environment. The body then is able to overcome the bacterial sort of attacking it, and therefore it slowly puts calcium and phosphate ions in, and you get saliva. Actually, you get mercaptans and sulfur ions coming in, sulfur salts coming in from the mouth, and therefore all sulfur salts are black, and that's why arrested caries is black. Every dentist has seen it. You see, so therefore, if what we should be doing is creating an environment that actually turns sort of carious dentine into arrested caries. And that's what I'm talking about, the pharmacological management of caries. You see, so I mean basically what the model we have at the moment is amputation dentistry. It's iatrogenic, and it leads to all sorts of problems. Because you're removing tooth structure, which we know that we know we can have arrested caries, but we're removing tooth structure, which we know we can arrest. So what we do is, as you have a cut on your hand, you put, if you left it there, it would eventually heal. Is that right? But if you put a bit of iodine on that cut, it's going to heal a lot faster. So that you treat caries.
Why? Because
the iodine sort of kills the bacteria and allows the body to get on with the process of healing. You know, that the iodine's working with the body to actually heal it. Now, if you put a pharmacological sort of medicament on the caries and you kill the bacteria, then you allow the body's natural healing process to go ahead and turn that carious infected dentine into arrested caries.
And what is the pharmacological agent?
Well, what I've been using is silver fluoride, diamine silver fluoride.
Silver?
Diamine silver fluoride, or silver diamine fluoride, sorry.
Which one? Silver diamine fluoride.
Yeah, SDF, yeah.
And every time someone takes a 2-year-old to the pediatric dentist and they've got 6 or 7 cavities,
They get a general anaesthetic.
they take them to general anesthetic, and the United States is a huge country.
Yeah.
So with that many people, that many kids, it seems like in the States at least one every 3 months dies.
Yeah. In Victoria, there's 4,000 children. This is the state that I live in Australia. There's probably, what, 4.5.
You call it a state or a province?
It's a state. Like America, we have states.
And how many states do you have in Australia?
We have 7 states.
7 states.
Yeah, 7 states and one territory.
One territory.
Yeah, which is but like the Yukon, I suppose.
And what does Canada have? 9?
Oh, don't ask me that.
9 states. And,
I've got no idea.
Okay, so what were you going to say?
So there's 4,000 children given general anaesthetics in Victoria every year. There's about 4.5 million people, and there's evidence coming out showing that if you give a child under 6 a general anaesthetic, it's dangerous, and also it causes long-term brain damage. So, I mean, it's
general anaesthetic does?
General anaesthetic to a child does. You know, general anaesthetics for old people and young people are pretty dangerous things.
Yeah, with the young people, they don't have the respiratory reserve.
Yeah, that's right. And young kids can actually sort of lead to sort of brain damage. And
little kids can go from a 96% saturation rate to.
I'm out of my field. So
yeah, but I mean, you can drop almost zero.
There's a lot of evidence coming through now showing that it's a very dangerous.
And what do you
thing.
say is old?
But starting to get older than me, older than about 80. If you get to 80,
so what would be the age too young and too old?
People getting in their mid 80s, it becomes very dangerous, or can become. You have an 85-year-old gets a general anaesthetic, they're never quite the same afterwards. Yeah. You know, it affects their memory and sort of thing.
Yeah, and but every time this happens, and the media is intense because they never go in there and show that. Like what's the data for how many deaths per?
I don't know, but I know that it's a statistic that sort of that the profession seems to push under the rug.
Do you know any of the statistics?
I don't know the statistics.
So the point I'm making is that they're always going to come out and say, journalism would say, the anesthesiologist would say, well, if you put 1 million people under, someone's not going to come out. I mean,
yes. But children are more susceptible.
Yeah.
Then children and older adults are the ones who are more susceptible.
Yeah. And that's why.
Yeah. Well, I mean, the fact is that it really is the whole process of this of silver diamine fluoride means that you don't have to give the kid a shot, you don't have to drill, and the kid comes in, they open their mouths, you paint the silver diamine fluoride on their teeth, and it stops the caries. Okay, it doesn't. You may have to come back at a later date and put a restoration in there because you're obviously going to get orthodontic problems if there's a gap there. But the food pack, you never see a kid in an emergency room with a food pack. Is that right? But you often
never
see
a
kids
kid in the emergency room with a what?
With a food pack, food stuck between their teeth. But you see a lot of kids in an emergency room with dental abscesses.
Yeah.
You see, and so that's the difference. So there's 2 ways of doing it. Sort of, we've got the silver. You put the silver diamine fluoride on by itself, and you've got to do it a couple of times a year. Okay, and
is every 6 months enough?
No, every couple of sorry, you've got to probably annually put it on annually. Okay, now
just once a year.
Probably once a year, yeah, once a year. Now the thing that what I did my PhD on was actually combining the silver fluoride with potassium iodide, because there's two issues with the silver fluoride. Is that the restoration goes in place okay, but because the silver fluctuates out into the cavity, then everything goes black. And also the silver then reacts with sulfides in the mouth, and of course you get silver sulfide forms, and that's black. So the problem is that you keep your teeth, but the teeth go black, and that's probably okay in periodontics, but you don't get too many adults lining up to have fillings where the teeth are going to go black. All right. So the idea was, a friend of mine called Graham Craig, who did his PhD when I should have been doing mine, said, and he did it on this silver fluoride, silver diamond fluoride, and he said what I would have done if I had my time again was to put the silver fluoride on and then put potassium iodide on, because potassium iodide also is a medicament, and it reacts with the silver fluoride, and it reacts with the silver fluoride and forms silver iodide. So any free silver ions that haven't bound onto the collagen fibres in the dentine then reacts with the potassium iodide to form silver iodide, which is a creamy white precipitate. And also the research I did shows that the silver diamine fluoride reacting, or the silver fluoride and the potassium iodide, is more efficacious in reducing the viability of bacteria than silver fluoride by itself. So you don't get the staining and you get an enhanced response. And so, but the difference here is that what you need to do with this technique, you need to actually cover it with a glass on of cement. Okay, so you actually sort of put a coating. You actually put the silver fluoride on, and then you either put
silver fluoride or silver diamine fluoride.
Silver diamine fluoride. Okay, you put the silver diamine fluoride on, and then you put the potassium iodide on immediately. Look, the technique is basically sort of quick smart. In fact, I've got a protocol here.
Why don't you make an online C course for Dental Town on it?
Yeah, I certainly will. I've got the protocol there. But this is when I'd finished the PhD, the chap I did it with, Graham Craig, we tried to make this thing commercial ourselves and couldn't. No, it's just too hard. Went to SDI, which is the biggest dental company in Australia, and they actually sort of took it to market for us, and on this product called Rebastar.
So why don't you make this an online CE course?
Yeah, well, I'm very happy to do so. Yeah, that's the sort of I'm not very good at this sort of thing, but
not very good at what sort of thing?
At marketing. I'm a humble fang farrier.
Well, I mean, it's so important.
Yeah.
So
well, this is what it comes in. It comes in these little capsules.
Okay, so this is the.
This is
the silver capsule.
That's the silver capsule.
Now, does this have to be triturated?
No, just it's a liquid, and it comes in, and you actually sort of burst it with a silver brush, like that, and then you just brush it on the teeth. And the fact is that
you take the silver brush, and pop through there.
Pop through there and paint it on. So the silver diamine fluoride has got a lot of ammonia in it, and therefore it's very volatile, and so therefore it's necessary to have an individual presentation each time. And then
you put on the silver diamine fluoride.
Yeah, and then after that you actually take the green capsule.
Is the potassium iodide.
Which is the potassium iodide.
And here's your instruction card.
Well, the instructions card are for desensitizing, because the TGA and the FDA haven't approved it yet as an anti-caries agent, although it's on the verge of being...
Who hasn't approved it?
FDA, and the TGA is our equivalent to FDA.
For Australia?
Yeah.
So you can't sell this
we can sell it as a desensitizing agent, but dentists are using it as off sort of instructions. They're using it as it's being used in the States at the same time. In fact, there's a product in the States that
is anybody doing this in the States?
Well, they're just selling the silver diamine fluoride, but the trouble is everything goes black. No one's selling the potassium iodide.
Have you talked to Jeanette McLean?
No, I haven't. Well, I know all I know is that SDI is the company is trying very hard with the FDA. It's almost on the cusp of being accepted into the United States.
Can you write an article about using it as anti-caries?
Yeah, I got lots of articles. Yeah.
Why don't you put one in Dental Town magazine?
I certainly will. Okay.
And then make an online CE course.
I'm very happy to do that. Yeah. All right. But I said, if you want the protocol,
because the reason I'm very concerned about this is that, I got grandkids. I got a 5-year-old granddaughter, Taylor.
I go and have a general anesthetic.
And you shouldn't. It's the pediatric dentist. It's so controversial in the dental anesthetics, but god dang, I don't want my 2-year-old grandchild being put under a GA, and it's just high risk. And I want to tell you another deal. For all you guys out there who think that's scaremongering, whatever, I know a dentist who's a dental anesthesiologist who went to dental school, got a dental degree, went and got his 2-year board-certified dental anesthesiologist, and his wife made him quit. He was going around to pediatric dental offices and doing GAs. And he kept waking up in the middle of the night screaming because he kept having nightmares that he was losing a tooth.
Losing these kids, yeah.
And after 2 or 3 years of this, his wife said, it's not worth it. I don't care. You can't do this anymore. And he quit doing it, and he just became a general dentist.
Yeah. But there's not a lot of interest amongst the paediatric dentists to stop doing general anaesthetics.
There's not a lot of interest?
It doesn't seem to be here in Australia.
And why do you think that is? Money's the answer. What's the question?
I don't want to say that.
Well, I mean, what else? Come on, you've been around the block. What do you think it is?
Well, it seems to me that there's certainly it's an easy way to manage it, and
No, it's Dentistry Uncensored. Come on, punch him.
Well, it's obviously I think there's a lot of paediatric dentists who think this technique applies the fiscal sphincter.
Say that again.
Applies the fiscal sphincter.
Applies a fiscal sphincter.
Yeah.
Because they don't get the money of.
I had a friend of my wife, her grandson in Sydney, was told she needed a general anaesthetic for her son, and it was going to be $3,000 or something. But they came down to, and I said, well, come bring her down to Melbourne. I had the kid in, the kid saying, where's the needle? Where's the needle? And he was terrified of injections. That's why I needed the general anaesthetic. Spent a bit of time talking to him, just painted the stuff on, put the glass on cement on top. The kid was in the chair for half an hour, no anaesthetic, kid walks out, no problems. And you come back, and with these, if you come back and sort of re-entry into these lesions sort of 6 months later, then the Caries dentine is as hard as a rock.
Now, is this mostly a pediatric dentistry product, or?
Well, I use it for everything. I mean, the fact is that I mainly use it for root canals. The fact is that I've not had a root canal fail since I've been using this material. And I do sort of redoing root canals. I find that I used to send root canals out to redo it. It really is amazing that what it does, you see, you can't get a biofilm on a surface that's been treated with silver fluoride and potassium iodide. And that information, if you go to my website, is published on that. I've got all the articles.
So what do you mean you're not doing a root canal? So instead of...
what you do is before you obturate, it's an adjunct, it's not an alternative. Before you obturate, you just put the silver fluoride in the pulp chamber and go with a reamer to 0.5 millimetre or millimetre of the apex. And you put the potassium iodide in and 0.5 ml of the apex. And then you wash it out, a couple of paper points in, and then you obturate. But the fact is that you line the entire lining of the root canal with silver iodide, and you can't get a biofilm on a surface that's been treated with silver iodide.
So have you had any endodontists agree with this?
I've got a endodontists which are interested, but the fact is, again, there's not a lot of interest in the profession.
By endodontists?
It doesn't seem to be. I mean, I try and talk to them very enthusiastically, and they're not terribly enthusiastic about it.
Well, Dental Town has a very vibrant community. If you posted that on Dental Town under endodontist, I guarantee you many of the endodontists would engage you and try it.
Yeah, I mean, I've got a friend who's a retired ENT surgeon, and he went interstate and had some root canals done, and came back and said, you dentists are so expensive. This is coming from an ENT surgeon, mind you. You do these root canals and they don't work, and I've got to give myself I've got to give myself on a course of antibiotics every 3 months. I said, Peter, do you want to be a laboratory dog? He looked at me and said, I'll be a laboratory dog. So I took him came to the office, took out the old root canal with just an engine reamer, and reamed it out, flushed it out with water, didn't use any sodium hypochlorite. I put the silver fluoride up there, potassium iodide up there, and just put a glass almond cement dressing on it. Now I did this in.
What did you treat it with?
I didn't. I just left it. It's a laboratory dog, you see. So we're doing it. So all I did, I put a GP point up there in case it sort of ossified and I couldn't redo it again. Now I did this in 2007, and since then he hasn't had any antibiotics, and there's trabeculation growing around where the root canal was, and that's just the.
And let me tell you, I know that people in the United States think that everything starts and ends in the United States, but it was the Australians the Americans were surgically removing all the ulcers. I was down here in Australia.
That guy, that's right.
That said, it's a bacteria. That's a bacteria.
Yeah.
And the Americans didn't listen to him for 10 years. And now they're doing it again down here with fecal matter transplants.
Oh, yeah.
Where in the United States,
they're be happy about that.
They're blasting people with all this chemotherapy and radiation, and people are laying around lifeless.
Yeah.
And it was down here in Australia where they realized, okay, a human's only 1 trillion cells.
Right.
But they got 10 trillion microorganisms, parasites, fungi, bacteria in the stomach lining. You're killing all that.
Yeah.
And these guys are laying around lifeless, so they'll go get a sibling and they'll start having them poop in the deal and then give them an enema to repopulate their deal. And people are noticeably springing back
That's
to
right.
life.
Yeah. Well, I think there's more living cells on a human that aren't human.
Yeah, 10 to 1.
Yeah, that's right.
Yeah, it's something crazy.
Yeah.
It's like 95% of all the DNA in your body did not come from your mom and dad.
Pretty scary.
Yeah, and with my children, half of their DNA is alien. I think that's strange, Ryan. But you're part alien. But very, very interesting. But I think that if you would post this under endodontics,
Right.
you get some endodontists looking into it. And
But so the whole thing with it's got amazing applications in the sort of developing economies too.
right.
I go up every year into East Timor, Timor-Leste.
Oh, I know you do.
And the first year I went up, I took the silver fluoride with me, and no other dentist didn't want to know it. What's that stuff? You see, and I was painting it on kids' teeth. Went up next year, and I came a week after the crowd that went up there, and they said, look, we're seeing some really strange things up here. We're seeing these sort of large carious lesions, but they're absolutely rock hard, and we just can't scratch them. He said, what's going on? And I said, that's the silver fluoride. So that was the thing, and now they can't do without it. And I sort of came up and mentored a young hygienist to actually use this. In 2 days, she saw 121 children and treated 257 carious lesions. Now you see how this fits into public health dentistry.
And this is East Timor.
It's in East Timor.
And this is why I've always kind of scolded dentists on Dental Town, because they don't realize that that the whole world is watching these conversations. And I've been in several countries in Africa where they are reading on Dental Town where amalgam is bad.
Yeah.
So they're trying to do direct composites, but they don't have high speed suction. And I watched this dentist in Africa, and he drilled out the composite, and I mean the woman stopped every couple of minutes, the patient, and rinsed out with water and spit in a bucket.
Right. Okay.
So he acid etches, and then he puts on the primer, and then she sits up, rinses, spits in a bucket, and then he goes back and put on the bonding agent, and then he cures it. Then she sits up, rinses, spits in a bucket. Then he adds the composite and cures it. Then spends like 30 minutes doing this amazing polish. And I'm like, This
And it's
is
not
a disaster.
yeah.
And when so there's 2 million dentists, and 500,000 of them practice like you do in Australia and we do in the United States and Canada and Western Europe. But there's 1,500,000 dentists in Africa, Asia, and Latin America that there's market segmentation and procedures.
Yeah.
And when you try to sit there and say the whole world is going to have one standard of dentistry, it's not very public health minded. Like, explain the difference in East Timor and Melbourne.
Well, it's the same sort of thing. You spit in a bucket, but the way
And how many people live there in East Timor?
probably 600,000. But I mean, there's virtually no dentists at all. There's two or three dentists for the whole community.
So 600,000 people.
Yeah.
Have
I mean, what happens? East Timor. I mean, it's a lovely country, but they suffered. There was this uprising against. They got their independence, and Indonesia came through, and there was a lot of people were killed, and so it's a recovering economy. What happens is the government. You've got a farming community where people are sort of digging yams and growing yams and this sort of thing, and the road comes in, and that's fantastic because the first thing that goes in is a healthcare clinic, because tuberculosis is endemic in East Timor, so everyone gets treated. Everybody gets treated for tuberculosis, and that's great. And the next thing that comes in is a school. They build a school, and that's terrific. And the next thing that comes in is the mobile telephone tower. So everyone's on a cell phone. And that's where they get their cell phones from, I don't know, but the government gives them money, so everyone's got a cell phone. But the next thing that comes is the flour and the white sugar. And that's how we used to, when I was a dental student, that's how we used to give rats caries. And of course, is the kids' teeth and the adults' teeth too just fall apart. Because you imagine it takes 6 months to grow a crop of yams. You can just go down to the little shop and buy sort of a bag of flour and a bag of sugar and just make dampers. And of course, and so there's diabetes is on the rise, dental caries is out of control.
Well, that's what they did in Arizona. So Arizona, before World War II, there was no commercial air conditioner. So the state was mostly American Indian reservations.
Right.
And so then after World War II, they commercially make available a swamp cooler. And they had a bunch of military base out there, and 6 million World War II vets were coming in and out there, and so they liked Phoenix.
Right.
So the city started building. Well, the first thing they did is took the river water away from the Indians and channeled it into Phoenix and Tucson and all that stuff in exchange for giving them welfare. So they took them from farming to now eating processed foods.
Yeah.
And it's just...
it's diabetes and caries.
It's just diabetes and caries, and it's just...
Yeah, well, that's the trouble that happens to a lot of indigenous communities when they get the benefits of Western civilization.
Yeah.
But,
what were those benefits again?
diabetes and caries.
Diabetes, obesity, caries.
Yeah.
So let's get an online CE course on this.
Right, sure,
if you have some sample kits or whatever, you should post under Endodontics and post on.
Well, if anyone's interested in trying this, apparently the way it works is that I can, even though it hasn't been approved by the FDA, I can send a sample over as a dentist to another dentist for clinical evaluation. So you're not breaking any.
And how do they contact you?
Well, it's the my web. Well, contact me on the internet, or my email address is geoff at dentalk dentalk.com.au. Don't forget to put the AU on it, because if you just go dentalk.com, it goes to a dental laboratory in Thailand. They got the .com.
Dentalk.
It's DENTAL. Yeah. .au.
And they use for Austria?
For Australia.
Oh, okay. I thought we were in Austria.
Yeah, that's right.
I think my plane made a wrong turn. You also have another website, Prof Dent. PROFDENT.com.
Yeah.
What's the difference between Dentalk?
Well, the Prof Dent is a little manufacturing company I have that makes we make a number of things like bleaching products, and for dentists we make sort of alcohol and mouthwashes and handpiece oil, that sort of thing.
So what?
Savvy.
Oh, okay. So let me finish up with the silver diamine fluoride. There's no question that Japan and Australia and New Zealand.
The Japanese invented it.
No, what?
Silver diamine fluoride. See, at the end of the Second World War, and the Japanese took on all the benefits of Western civilization, which included a Western diet, and the teeth started to fall apart, and the Japanese government just didn't have a means of dealing with this, but they knew that people who painted their teeth with heavy metallic salts actually stopped caries. There was a process called umaguru, I think, where a woman got married and she painted her teeth with these silver fluoride. The teeth went black, and the samurai did the same thing. So when they sort of whipped your head off, you couldn't see the smile on their face, I suspect. But they also knew that if you actually did this, it stopped caries. So the Japanese government looked at a series of metal salts and said, well, this is and saffride was sold by saffride's been sold in the States. I think it's still available for 25 years.
Saffride?
Saffride, yeah. And that's
how do you spell that?
That's silver diamond fluoride. Morita, I think Morita sell it.
J. Morita?
Yeah.
A Japanese company.
Yeah. SAFORIDE. So it's been, there's nothing new about it. The only problem was that it used to turn teeth black. And this is why the good thing about this Rebastar is that it actually turns teeth.
And what was the Japanese tradition where they wanted the black teeth?
Oh, well, it was like a social status.
They still have that.
I'm not sure. There aren't too many samurai running around at the moment.
No, but when we were in Tokyo, Ryan and I were in Tokyo not very long ago, and there still is underground. Did you remember seeing that, Ryan? Where there were some beautiful women with black jet black teeth.
Well, it's a cultural thing in Japan. I mean, that's fine.
My favorite culture is Buddhism, because they worship a short, fat, bald guy with a big belly. That's the culture I'm trying to promote the most.
You're looking for sort of the physical transformation.
I want everyone to think that a bald guy with a big belly and a smile on his face is God. Yeah. Can we promote that more?
I'm very happy to do that for
you. But what I was going with is the fact that the Americans had a really great restorative filling when I got out of school called an amalgam.
Yeah. And
it was metal. It was all antibacterial. It was half mercury. The other half was silver, zinc, copper, tin. All antibacterial.
Right.
Lasts about 30 years.
Black. Yeah, we all learned about
And they
black.
replaced it with a direct composite, which is inert plastic and is lasting about 6.5 years.
Yeah. And releases hormones. Sort of turn boys into girls and all sorts of things.
But in Japan and Australia and New Zealand, you guys use a lot more glass ornament.
We use glass ornament, yeah. Well, glass ornament. See, the thing is, look.
So I want you to talk about why do you think the Americans use direct resin composite?
Okay,
and why do you think?
Well, let me ask you a question. Okay, if we talked earlier about the fact is that you can leave the dental schools now agree that you can leave. Affected dentine, but not infected dentine. Okay, and we talked about that. So therefore, if composite resin was there to restore a carious lesion, then sure the manufacturers would say on their spiel, this is the bond strength of this dentine bonding agent to affected dentine. What's the bond strength of affected dentine, of dentine bonding agent to affected dentine?
0.
Well, very small, you see. And the fact you can't tell where you're infected, or you can tell when you're in infected caries. You can't tell the interface between infected and affected, and you can't tell the interface between affected and sound dentine. That's just by feel. So if you're restoring a tooth, you're restoring a carious lesion for a composite resin, what you've got to do, you've got to remove all the infected dentine and all the affected dentine. And just to make sure, you've got to get some sound dentine away from it. So you're taking away all this tissue, which is basically iatrogenic amputation of remineralisable tissue. It's bizarre. But if you use a glass ornament cement, you see the glass ornament cements pump out when you mix it up, it's got quite a low pH of about sort of 1.5 to 2, and therefore it dissolves the outer layer of the apatite crystals. And then what happens then is that so that you get in solution, then you actually, the apatite, when it actually sort of sets, pH of 7, it doesn't shrink, and you've got all this sort of this 1% fluoride release. Now 1% fluoride release is about 5,500 parts per million. So therefore, if you've got 2,000 parts per million, you'll kill strep mutans, the main sort of bugs, one of the main bugs that cause caries. So you can leave a thin layer of infected dentine. So you can leave all the affected dentine and the sound dentine underneath. So it's about a millimetre of tissue you can leave, and the glass ionomer cement then will form a biological seal. It's pumped. You get calcium and phosphate ions percolating up through the dentinal tubules. You get the fluoride coming out from the glass ionomer cement, and strontium or calcium depending on the product. And what happens then is that this sort of the softened, you kill the bacteria, so you get a thin layer of dental scar tissue, arrested caries, where you leave the caries behind. But all the affected dentine, which is carbonated apatite, when a tooth forms, it's got carbonated apatite or freshly erupted tooth. It's got a remineralisation, demineralisation pH of 5.5. But once it actually forms into fluorapatite, it's got a remineralisation, demineralisation pH of 4.5, so 5.5 to 4.5. So it's one pH drop lower, which that's 10 times more effective. So what you're doing is, if you restore a tooth with glass ionomer cement and you leave the affected dentine behind, you're turning the affected dentine from a carbonate apatite into a fluorapatite, and therefore it's 10 times more effective against caries. So you've got a caries-resistant base on the base of your restoration. If you restore a tooth with composite resin, and particularly if you've got, say, subgingival preparation on the gingival on the floor of a proximal box, when all the dentinal tubules are running that way and it's percolating out fluid, what sort of bond strength are you going to get with a dentine bonding agent on dentinal tubular fluid? Whereas the glass ionomer cement is a water-based material which will bond to a wetted surface. I mean, every way you look at it, I mean, you just cannot. I mean, dentists in Australia really can't quite understand why there's this overwhelming sort of rejection of glass ionomer cement in the United States.
But where is it accepted? Japan, Australia?
No, not Japan. No, Japan. Japan's driven by their healthcare system, I believe. I think a lot of the dentistry in Japan, they do these stainless steel inlays, because that's what the healthcare system pays for. It may be different now, but that's what it used to be like.
So where is glass ionomer mostly used?
Well, it's used in Australia, New Zealand, in Europe and Britain. It's used a lot in the UK. It's used a lot in Scandinavia. Not so much in sort of Germany. That's sort of the Europeans tend to follow the American model, as does South America. But the fact is that you ask in the States what's the most common lecture you like to hear, they talk about post-operative sensitivity. Australians don't have post-operative sensitivity because they use a glass ionomer base. Basically the trick is to do a sandwich. The glass ionomer cement has got a lot of biomimetic properties, and those biomimetic properties are the factors that it actually sort of helps heal a tooth. It works with a tooth, not on a tooth. But the fact is it doesn't have the strength, and so therefore if you go put a composite resin overlay on top of glass ionomer cement, that's the ideal sort of restoration. As John McLean, who was a very famous English dentist, said, that you replace the dentine with a glass ionomer cement and you replace the enamel with composite resin.
And he's from the UK?
Yeah, well, he's dead now, but he said that 30 years ago. And Graham Mount, who was one of the great proponents of glass ionomer cement here in Australia.
Graham Mount?
Graham Mount, yeah. He was one of the reasons why glass ionomer cements became so popular in Australia.
And would you credit Graham Milicic for New Zealand?
Oh, well, Graham Mount. No, Graham Milicic and I sort of came after Graham Mount. Graham Mount sort of set the stage in Australia and New Zealand, and Graham and I sort of picked up the baton and ran with it.
So the Graham Mount, and then
well, Graham sort of, well, I mean, there's been a lot of people like Graham Craig. There's been a lot of,
The United States had graham cracker. The graham cracker?
Oh, the cracker, yeah,
Yeah, that's called a graham cracker.
the graham cracker, okay.
You know that was a medication?
Was it?
Yeah, it was made by a doctor. It was Dr. Graham.
Yeah.
And he made the graham cracker for people who had upset stomachs. And I'm serious.
Right,
I'm
okay.
serious. It was originally a medication.
Right, okay.
Yeah, I was just...
That's some information.
Yeah. But truthful and funny.
Yeah, so that's why there's that. I mean, that really is. It's one of the fascinations of dentistry. Why in different parts of the world you get this.
Well, I love that the most. I think the greatest education that I've had in my life. I don't know if it was actually college or even reading books. I think it was more international travel, because when you're born in a tribe, you pretty much learn their. You just swallow and believe their religion, their food, their cultures, their customs. And when you start going around the world and you say, okay, everybody has a toilet, but everybody makes it slightly different.
That's right.
Everybody has a window, but everything's just slightly different. And I love the fact of dentistry. It's the little nuances, and that's why I love my favorite meeting is that SDI meeting in Cologne you're talking about. What does that stand? No, FDI.
IDS. The IDS meeting, yeah.
International
Dental Show or something.
International Dental Show. It's in Cologne, Germany, every other year.
And it's so big. I mean,
over 100,000 dentists come.
Yeah, and you can't walk around it in the time of the show. You can't visit you can walk around it, but you can't visit every stand.
If you were just walking like you were walking to the park, you could not walk by every booth in 5 days.
Yeah, yeah.
And you'll stop, and these dentists could be from Pakistan, Turkey, India, everywhere, every single country on earth. And you listen to them, and it's just amazing.
Everyone's
how
got a
the
different way
human
of looking
mind
at it. Yeah.
sees you're looking in the same mouth. By the way, those bugs, you said Streptococcus mutans, the research is showing that by the time you get 4 millimeters down into a cavity, there are no Streptococcus mutans. And in that layer, they're discovering a new bacteria every 3 months.
Oh, sure, yeah. I mean, it's very complicated but you need the strep mutans, the lactobacillus, and they're the ones that initiate the create environment where you can get these sort of more complex bacteria actually coming in and sort of again propagating the disease. But interesting enough, though,
and the reimbursement is huge because they only treat if they only pay you for drilling and filling and billing, and there's no procedure to pay for prevention, that definitely changes outcome.
But see, drilling and filling is working on the teeth, and that's it's an iatrogenic amputation model. But this sort of pharmacological caries management is working with the teeth to help the teeth do what they can do anyway, and that is remineralise and form. The infected dentine or the carious dentines forms arrested caries, which is dental scar tissue, and the affected dentine actually forms goes from a carbonate appetite to a fluorapatite, which is 10 times more resistant to further tooth decay. And that's and that's why the glass armor cement is such a superior restorative material to use than composite resin. Composite resin's all right for replacing existing restorations. You notice when you see a technique where a dentist shows how to do a good composite resin, they never show you treating caries. They also take an old filling out, an old restoration out, put a new one in. Have you noticed that? They never show you how to treat a carious lesion. Just think about it. It's always taking out an old filling. Yeah. Because the manufacturers know that it gets very tricky when you start actually start using a composite resin on a carious lesion, because you've got to take out all the infected and affected and some of the sound dentine. So you're making a huge iatrogenic hole in that tooth.
So what is the status of water fluoridation in Australia?
Yeah, pretty good. Most of the all the capital cities are fluoridated except for Queensland and Brisbane, and that's because that's a political thing. But we have you have governors, we have premiers that run our states, and in Queensland there's a lady called Anna Bligh, and the state was in big financial trouble, and she found out that if they fluoridated the water supply, then the public health dental service would save $200 million over 3 years because of the fluoridation of the water supply. And she just did it. And all the rat bags and the nutters started screaming and yelling, saying it was sort of forced medication, all that sort of stuff that goes on. And but basically Australia's pretty good.
Yeah, it's amazing with the advent of social media, and you see large numbers of dentists on social media. It's amazing how many millennial dentists are not buying into water fluoridation. Why do you think some of the younger dentists that are like under 30
don't want it? I can't. I mean, look, one of the big problems here in Melbourne, a dental degree now costs $300,000, or pretty close to $300,000. Now, your government gives you a loan, but you've got to pay the loan back. Okay, so these kids graduate with a $300,000 debt, 7 years it takes, and then they've got to go into a practice. And so the trouble is, when you go out into the big wide world, everything looks like an implant or a crown or a bridge, because they're trying to sort of cover this sort of huge debt they've got. And so there's a lot of social dislocation. I mean, I think it's very, I think you might say it's not entirely ethical of the universities to be, because we've got 5 new universities in Australia in the last sort of 7 or 8 years. So apart from the old sandstone universities in each of the states, we've got 5 more universities. So they're turning out sort of more and more dentists, which is a problem. And the other thing is it's the old people like me who've got the cavities. Generation X doesn't have cavities. There are plenty of cavities out there in the public sector, but the sort of the middle classes that can afford to used to going to a private dentist. My kids don't have any cavities, and my friends' kids don't have any cavities. And I talk to patients, and I know my kids don't have any cavities, but someone will come in, they've got a root canal, or they've got a filling that's broken, or they've got to have something replaced. So in 15 years' time, when the baby boomers have left the mortal coil, there's not going to be a lot of work around, and not in the private sector. And I suspect it's the same in the US.
The dentist is really, he's just crawling along. I mean, it seems like a dentist anymore is just to create jobs for the universities, create jobs for the people selling all the high expensive equipment.
Yeah. Well, see, the thing is that
create jobs for all of his staff. I mean, he's really just a huge economic burden.
Yeah.
I mean, he's got a graduating dentist has a target on his back. He's got to feed academia. He's got to feed all the big equipment manufacturers. He's got to employ 5, 6, 7 people. It's kind of an economic burden.
And they're still graduating with this sort of amputation iatrogenic model, which is then feeding into the dental industry, where you've got sort of, I said, go to IDS, and 76% of the displays are talking about restoring teeth or doing implants. So the whole thing is just, it's churning on, but the whole thing is predicated on the continuation of caries and tooth loss. I mean, it's just it's like the whole thing has been hijacked by technology and industry, and the dentists are just being sort of sucked along in the process.
So you have another product. So you have 2 websites. You have dentalk.com.au.
Yeah.
But you have profdent.com.au, and that is what you were showing me.
No, this is the well, one of the things that fascinated me as a dentist is there's a big demand for bleaching. I do a lot of bleaching in the practice, and I used to really hate taking impressions. You see, we can't get our assistants to do it, our dental assistants. Well, the government won't let us do it, so we've got to take all
Well, how will the government catch you?
Don't go there.
Don't go there?
Don't go there, no.
Remember, laws are just suggestions.
Yeah, I know.
Just
Anyway,
suggestions.
we make this thing called Now, which is and I'd sort of, because you say to a patient, would they like to bleach your teeth? They say yes. I say, would you like to do it now? So basically,
now.
You see, that's what it is. So what it is,
when it's upside down, it looks like moo.
That's right, but it's.
I'm reading moo.
Movie,
But you turn upside down, it's now.
So what you've got you've got a universal tray. So the lower's got lower on it, so it can't be confused, and the upper's got upper on it, and basically you actually get this. It's a very viscous gel, and you actually sort of get the gel, and you can see how viscous it is.
So what is it? Carbamide peroxide?
Straight carbamide peroxide. Yeah.
10%.
Well, we've got 16% and 10%.
16% and 10%.
Yeah.
And which one do you recommend?
Well, if people react to the 16%, you give them 10%. 10% doesn't cause any problems. I mean, we sell other bleaching products, and the 10% is more popular amongst dentists because they give it to patients, and the patients aren't going to give them any angst. Whereas 16% works faster, but basically they're going to get sensitivity.
You know what I tell my patients? I tell them that if someone brushes and flosses every morning and every night, they have zero gingivitis, 16% is always fine. And that everybody that I know that has sensitivity is because they have bleeding gums, they're not daily flossers. And I believe that when you start soaking your teeth in carbamide peroxide, it really starts curing gingivitis rapidly.
Yeah.
And I just say, well, if they say, well, it's stinging and it's sensitive, and I just say, well, come on, do you really floss every morning and night? And they go, no.
But you don't need to floss every morning and night.
Well, if you have any bleeding and you put 16% bleach on you, that's the sting.
Yeah, but the thing is that the flossing the only reason you floss is to get the interproximal plaque out between your teeth, so the saliva can wash through and take away the acid and toxins. And people see, if you say to someone, you've got to floss every day, people say, well, I can't floss every day, so they don't do it at all. But you say, look, I say, you've got a built-in meter. If you floss and you spit out blood, you're not doing it enough. But if you floss and you don't spit out blood, and that probably means sort of 2 or 3 times a week, then that's fine, because it takes that long for the bacteria to produce the mucopolysaccharides.
And don't you think there should be it should be legal to have red toothpaste? I can't believe how many.
They used to sell a cochineal toothpaste. They still do they?
They sell what?
A cochineal toothpaste that was
close-ups red.
Close-up red. Yeah.
I saw a patient say, well, how do you? I mean, the toothpaste is red, and I said, well, you can't have red toothpaste. You need white toothpaste and a white sink to see blood.
Yeah. Well, the cochineal used to actually stain the gums pink, and therefore it makes the teeth look really white. But when I was a young graduate, I was selling this cochineal toothpaste with cochineal in it, which actually sort of make the gums go bright red, and the teeth would go bright white.
So if they go to your website, profdent.com.au, they can order these pre-made, so they no longer have to take alginates or models.
Yeah, and they can put them. They can put.
And how much are these pre-made trays?
Well, we sell them to dentists the kit sells to dentists for 98 Australian dollars, which is probably about 70 US.
So that comes with the trays and one tube of gel.
Yeah, with 30 mils of gel, which is
30 milliliters.
Yeah.
That's the only metric that Americans know is milliliters. They don't know kilometers. How many kilometers is a marathon?
46.
46?
So, sorry, 42.
42?
Yeah. 42 kilometers.
Well, I love this part. For $70 you get the upper and lower. Who's making your trays for you? Do you make?
We get a company in Melbourne makes them. I think they made the molds were made in China, but they actually make them here in Melbourne.
And are you selling them in the United States?
No, we're not selling any in the United States. We're just trying to get it off the ground here in Australia.
Well, I think
one of the things that
you should post that on Dental Town under tooth whitening.
Yeah, people say to me, doctor, can we talk about whitening? And I'd say, would you like to do it now? So that's where it came from. I said, wow, that'd be good. So the fact is that I charge $180 for it. That's Australian. So you're making the cost of a prophylaxis virtually for nothing. So you actually so if someone comes in for a checkup and a prophylaxis, you get for the price of you actually get a margin for checkup, and they get 2 prophylaxes, and that makes it.
Nice.
That makes it sort of a very, very easy way. Or say after a kid finishes a set of orthodontic treatment, so the orthodontist can say, well, he would just give them a kit and say, look, now you've got such lovely straight teeth. Now here's an opportunity to make them white. And instead of having to make special trays, etc., they just give them that, and off the kids goes. And so it's got, it's certainly got it. It's a niche product in the industry. It's not going to take away from professional bleaching, but.
And why not?
Because dentists still like to get the margin they get for professional bleaching, I think.
Do you think the bleaching light does anything?
That's one of the biggest. Ray Bertolotti, my friend Ray Bertolotti, got the bleach, and he bleached every second tooth, and he got the light on it, and after 20 minutes he said he had a zebra smile. White teeth, dark teeth, white teeth, dark teeth. 3 days later, back to where it was before. Okay, all the bleaching light does is dehydrate the teeth. That's been well and truly documented.
Yeah, and the only company that I really know that was ethical enough not to sell the bleaching light, you know which one?
What?
Dan Fisher of Ultradent.
Yeah,
He said I cannot
See
sell the light
yeah.
when all the research says it does nothing, and that hurt his sales.
Yeah.
And he sells opalescence and
Right,
the deal. And all these dentists are like, well, I know it doesn't work, but the patients want the light. And he was like, well, you're a doctor.
Yeah.
So you're going to say, okay, I'm going to use the light because
we're under these
the patient
pressures.
wants one?
We're under these pressures because the people see everything in our society these days, people want it. They want it now, and they want it immediately. They don't have to, and they want it for free, and they don't want it to hurt. That's basically the.
I have a friend who's a podiatrist,
Yeah.
and he says I can when I'm removing a bunion. He says I put him to sleep. He says I take a 15 blade, I reflect, I remove the bunion really fast. But he goes, but when he says laser surgery on the foot, the phone just starts ringing off the hook. He says I can take a 15 blade and make the incision in 1 second.
Yeah.
But that laser, I'm cutting along and I'm cutting along and cutting along. So to tell you the truth, half the time I just start to use it, then I put it down and just take a 15 blade and do it. But he says that, so for him, the laser foot surgery, huge marketing.
Yeah. And also it makes your operatory smell like a Korean barbecue.
A Korean barbecue?
Yeah.
I have never smelled a Korean barbecue.
We've got a very multicultural society here in Melbourne, so there's a lot of Korean, and you go around, it's got a very particular smell, and that's what.
And what glass ionomer were you using with this? Who makes your glass ionomer?
I'm using the SDI one, but that's
so SDI's making glass ionomer.
Look, there are really good glass ionomers on the market. There's GC,
which is General Chemical.
No, GC Fuji.
But doesn't the GC stand for General Chemical?
I'm not sure. But everyone they call it GC. I mean, SDI used to stand for Southern Dental Industries, and they just call it SDI.
Yeah.
So you've got GC, you've got SDI, and you've got 3M, and they make they're the big sort of.
Yeah, I think GC is General Chemical, and they moved their headquarters from Tokyo to Switzerland.
No. Mr. Macau moved his headquarters from Tokyo. He moved from Tokyo to Switzerland, but he was the owner. But the company's still in Tokyo.
Yeah, but he moved the.
He moved himself.
To where? Switzerland.
Switzerland, yeah.
So did you think he did that for tax purposes?
Oh, no, he's a. I wouldn't suggest Mr. Macau do that. He's a really nice person.
Can you get him to come on my show on a podcast?
Yeah, he'd do that.
You email him?
You email him, yeah.
Email him and CC
No, don't get me. You email him. Don't get me to email him. You email him.
Well, can you give me his email address and his name and email?
I'm sure I can find it for you. Yeah.
Okay.
I mean, I've got to go through through the right channels, but yeah, I mean, he's a really interesting man. Sort of took it, to sort of the end of the war. Japan was sort of in terrible trouble, and he's taken this company, and it's one of the biggest, probably one of the most successful dental companies in the world.
Yeah, and what's his name?
Mr. Macau. Macow, I think.
Mr. Macow.
Yeah, I think Macau. Well, it's pronounced Macau, but it's probably spelt. It's a Japanese. It's English.
And who's the CEO of? I forgot his name. I had lunch with him of SDI.
Oh, Geoff Cheetham. Oh no, Samantha's his daughter now. Samantha Cheetham.
Did he retire?
No, Geoff is still Geoff Cheetham's still the chairman of the company, non-executive chairman.
Does he go to work every day, or is Samantha?
No, he
do
still
it?
goes to work. No, but Samantha does the nuts and bolts now. But Jeff's the non-executive chairman. She just sits on the board meetings and gives us all his blessing.
Well, tell Samantha I want to podcast her.
Certainly, I'm sure she'd be happy to do that.
And also, I think it'd be a great marketing story because now half the dentists coming out of school are women.
Yeah.
And she might be one of the few
she's a
women
very switched
CEOs
on,
of
very
dentistry.
switched on lady. She's got an MBA and all the stuff you need to sort of, and she's very much sort of hands-on. She's run that.
She's right here in Melbourne.
Right here in Melbourne.
Yeah, last time I was down here, we all went to lunch.
Yeah. Well, she's up in the snow at the moment, but
I've been in the snow. Where's the snow? New Zealand?
No, Mount Buller. We've got a ski resort.
That's where we claim. Is that where we claim?
No, that was Mount Kosciuszko. That's another one. But the closer one's about 120 miles away.
Yeah.
Out of Melbourne.
Oh, nice. Well, is there anything else that you want to talk about?
Look, I think that's about it. Yeah, it's I really enjoy it as always.
Yeah, and what were you telling me? You're saying that there's no way we could talk for an hour, and we went over an hour.
Did we? I did say that. I didn't think we would, but that's
that's what you were saying. We were climbing Mount.
When we went to climb Mount Kosciuszko, I think we sat in the car for sort of 4 hours on the first day, and you slept going up to Sydney, I think, so we didn't talk all that much. but it was just it was a very interesting experience, and thank you for the opportunity of being able to talk to you tonight too.
Well, hey, thanks. I love to go around the world and hear from the legends around the world.
I'm hardly a legend.
No, I know you're humble man.
In my lunchbox.
I know you're a humble man, but you're a legend here. You're a legend in the minds of every Australian dentist I know. And
well, you got a polarized response.
Everyone respects you, so it doesn't matter if you agree or disagree. They definitely listen and respect everything you're saying. And again, my pet peeve on this is that America seems to be killing a child with general sedation at least every 3 months. I mean, look at this. Look at. So if you go to Dental Town, and we have 50 categories, and one of the categories is pediatric dentistry. So we'll go to pediatric dentistry. And look at some of the names of these deals. That dentist in Texas that was charged.
Yeah, I mean it's certainly alternative to general anaesthetics for children. There's no doubt about that. And so you can also the thing is you can also treat for fissure protection. They don't call it fissure sealing. They call it fissure protection. If a kid's got a small interproximal lesion, what you do is you actually you put phosphoric acid on the teeth to clean it.
Look at this thread. Another death, and this thread is 7 pages long. I mean, just every time you turn around, there's another one. Another death. I mean, and Megan Kelly reports on sedation deaths. So have you heard of Megan Kelly?
No, I haven't.
She's a big famous journalist, and she's doing, she did a whole story on kids dying at the dentist. And the thing is that, you shouldn't die from having a cavity when you're 2 years old. And some of my mentors, my mentor, which I really wish she would meet, Jeanette McLean, who's a pediatric dentist in Phoenix, Arizona, where I live. I mean, and she made the cover of the New York Times talking about that. Why don't you use this silver diamond fluoride? This is someone you should put your product in the hands. She's got articles on Dental Town, but I think you guys would be
right. Well, I'll certainly look at
that.
Yeah.
You guys should meet.
All right.
So thank you for all you do for dentistry. All right.
Oh, it's a high five, isn't it?
Oh, it's a high five.
Hello, my name is Geoff Knight, and I'm a general dental practitioner from Melbourne. Dental implants play an important role in restorative dentistry. However, over the years, many patients have asked me if there are simpler, less invasive and less costly alternatives. The following bridging technique has a unique anchoring system within the enamel of the abutment tooth, resulting in a minimally invasive, less costly procedure that provides patients with the same aesthetic and functional outcomes as a dental implant. This young woman had been uncomfortably wearing a plastic denture for many years and was seeking a more secure replacement. A small restoration was removed from the mesial of the abutment tooth and incorporated into a tea preparation, prepared 2/3 of the way across the lingual surface towards the distal, and about 1.5 millimetres deep, mostly within enamel. This graph shows the three principles of tooth preparation. Prepare enamel to a depth of about 1.5 millimetres. The anti-rotation T design stabilises the pontic and the retainer in three directions. A slightly increased width and depth of the preparation at the margin to enable thickening of the retainer in this area and improve the strength of the bridge at the isthmus. A triple tray impression technique is employed. Heavy body impression paste is placed into the upper and lower sections of the tray and light bodied impression paste over the abutment area. The patient is then asked to close in a centric position once the tray has been inserted. Remove the tray once the impression paste has set. Observe the outline of the preparation within the abutment tooth, about 1.5 millimetres. Shade taking is achieved by photographing a Vita shade guide against the abutment tooth and emailing the photograph to the ceramist for colour matching. A temporary dressing is placed into the preparation prior to returning the denture and dismissing the patient for 10 working days until the prosthesis is ready for insertion. At the insertion visit, after removal of the denture, the temporary dressing is carefully removed with a high-speed flat fissure burr. The abutment tooth is then etched for 5 seconds with 37% phosphoric acid and thoroughly washed and dried. The bridge is next dried into the preparation to ensure a good fit of the retainer and that there is a correct colour match of the pontic. A mylar strip is next inserted on the distal surface of the abutment tooth and a small amount of resin modified glass ionomer cement is placed into the preparation and on the proximal surface. A small amount of resin modified glass ionomer cement is placed upon the retainer. With narrow incisors, it is sometimes advisable to place a white opaquer over the fitting surface of the retainer to block out any metal shine through on the labial surface of the abutment tooth. After the bridge has been inserted and gently pressed into position, another small increment of resin modified glass ionomer cement is placed over the retainer, followed by a small amount of composite resin. Composite resin is further placed into the join between the retainer and the pontic, and a perio probe is used to remove any excess cement from the gingival margin of the proximal surface. The mylar strip is then gently folded over the lingual surface of the retainer and pontic, and the patient is asked to close firmly into centric occlusion to achieve the correct positioning of the bridge. The steps for inserting the indirect internally retained bridge are summarised as follows. Firstly, etch the preparation for 5 seconds, wash and dry. Next, insert a suitable resin-modified glass ionomer cement into the preparation. Next, insert the retainer and the pontic. Next, cover the retainer with a small amount of composite resin. Next, overlay the retainer and pontic with a mylar strip and have the patient close firmly in centric occlusion. Next, photo-cure the labial section for 10 seconds, ask the patient to open and photo-cure the lingual surface for a further 10 seconds. Labial contouring is achieved with an 8-fluted tungsten carbide burr under a water spray. The occlusion is then checked in centric, lateral and protrusive movements and adjusted with a high-speed diamond burr under water spray. Check the occlusion again and carry out the final contouring with a slow-speed diamond sphere to ensure there are no interference on the lingual surface. The bridge is also finally finished using a rubber cup on both the lingual and labial aspects of the tooth. Proximal surface of the adjacent tooth is checked with dental floss and also would assure that there is no debris under the pontic or against the proximal surface of the abutment. This minimally invasive bridge easily matches the aesthetics of a dental implant. With less clinical time and laboratory fees involved to make this bridge, dentists can now offer their patients a comparable clinical outcome to a dental implant with substantial savings in both costs and the time involved. Direct fibre reinforced bridges are a minimally invasive, efficient and low-cost alternative to replacing missing teeth. Every patient presents with a unique clinical challenge, and I've specifically chosen these patients to show the wide range of treatment options that are available with this technique. The direct fibre reinforced bridge creates happy patients and is a sound practice builder. The upper left canine is a fibre reinforced resin crown that will be used as an abutment tooth. Trichloroacetic acid chemically cauterizes the gingival tissues, stopping clavicular exudates. An antidote solution of sodium bicarbonate is kept on hand when TCA is being applied. An access cavity is prepared to just over 1.5mm deep and 1mm wide on the mesial aspect of the abutment tooth. A carbon fibre post, composite post, is tried into the preparation prior to cementation. Fujibond LC is placed into the cavity and over the posts. A fibre reinforced composite resin, Nulite F, is placed into the preparation. The carbon fibre post is carefully positioned into the preparation to form the central core of the pontic. The preparation is light cured for 20 seconds. After cementing the post, Fujibond is again smeared over the exposed post and a white tint placed to opaque out the black carbon rod. Spot cure for 5 seconds. An increment of Nulite F is placed onto the carbon rod and carefully puddled around it to form the outer layer of the reinforced core. Cure for 20 seconds. Resin bond is placed over the lingual surface of the pontic and abutment tooth. An increment of Nulite F is placed over the lingual. A resin-impregnated section of ribbon fibre is placed onto the composite resin. The preparation is photo-cured for 20 seconds. A microfill resin is next placed over the lingual surface to cover the fibres. Prior to photo-curing, a 3 cm square section of freezer bag is placed on the uncured resin and the patient asked to close. The facial aspect is spot cured prior to opening and curing the lingual surfaces for a further 20 seconds. The lingual surfaces will only require a slight adjustment to clear the bite. A paladin sexual matrix is inserted under the pontic core with a concave surface against the abutment. This will form the contour for the gingival floor. Stabilising the matrix with a finger, an increment of capsulated Fuji 2LC is injected under the core and adapted with a plastic instrument. Still holding the matrix in place, the resin-modified glass ionomer cement is photo-cured for 20 seconds. Resin-modified glass ionomer cements produce a better tissue surface than resin. A micro brush is used to place resin bond over the facial surface. An increment of cervical shade microfill resin is puddled onto the pontic with a warts carver and the matrix is gently pushed into the gingival margins. The area is spot cured for 5 seconds. Bonding resin is placed again. An increment of body shade microfill resin is placed onto the pontic and contoured into shape with a warts carver. A small amount of white tint is placed into the resin and characterised onto the surface. Spot cure for 5 seconds. The lingual aspect of the sectional matrix is levered away from the pontic. A paper point is gently wedged into proximally and a mylar strip inserted. Positioned lingually between the pontic and the matrix. With the mylar strip secured, bonding resin is placed over the preparation. An increment of incisal shade microfill resin is placed proximally and worked over the incisal edge and onto the lingual margins. The strip is folded over the facial surface to facilitate the formation of the proximal margin. After spot curing for 5 seconds, the facial and lingual margins are each cured for a further 20 seconds. After placing a bonding resin, the proximal area between the abutment and the pontic is formed using an increment of incisal shade and forming it with a warts carver. The whole restoration is now photo cured for 20 seconds. The matrix band is removed with a pair of pliers, followed by the paper point prior to finishing. A 12-fluted tungsten carbide burr is used for initial cervical contouring. Bulk reduction of facial and incisal surfaces is carried out with a Moore's extra coarse emery disc. Lingual contouring is achieved using a high-speed round diamond burr. Lingual contour will be minimal due to prior occlusal adaptation. Finer contouring is carried out with a small, coarse, soft-flex interproximal disc. When the disc is reversed, it can be used for contouring the proximal surfaces of the bridge. Final occlusal adjustments are carried out with articulating paper registering centric, protrusive and lateral movements. It is essential that all occlusal interferences are identified and completely removed. A high-speed pear-shaped stone provides initial facial contouring. Polishing is commenced with a silicone rubber wheel on both facial and lingual surfaces. Proximal finishing is carried out with flexible abrasive strips. Dental floss confirms the absence of any roughness on the proximal and gingival surfaces. A final polish is carried out with a small, fine, soft-flex disc. The lingual view shows the reinforcing fibre. The facial view shows the natural contours and gingival adaptation that can be achieved using this construction technique. I've been providing these direct resin bridges now for over 25 years. While nothing works 100% of the time on 100% of the people, there are many patients who have been very happy to have received one. They're a great way to build your practice and a challenge that will enhance your enjoyment as a dental practitioner. If you'd like some more information about this technique or other videos in the series, I can be contacted on the following email or fax numbers, or check out the website. And thanks for watching this video. Rebastar, silver fluoride and potassium iodide. Open the tooth to gain access to the caries. Isolate the cavity with either rubber dam or cotton rolls. Remove superficial debris and the surface layer of caries with an excavator. Using a number 3 round slow speed burr, remove the carious dentine at the dento-enamel junction and cavity floor so as to encircle the caries with sound dentine. Apply super etch 37% phosphoric acid for 5 seconds and wash away with copious amounts of water. Dry, but do not desiccate the preparation. Pierce the foil cover over the grey silver fluoride reservoir using the grey brush. Rotate the brush to push the foil to the sides of the reservoir. Bend over the brush and remove the brush from the reservoir. Apply the silver fluoride solution liberally over the cavity preparation. Commence potassium iodide application immediately following silver fluoride application. Pierce the foil over the green potassium iodide reservoir using the green brush. Rotate the brush to push the foil to the sides of the reservoir. Bend over the brush and remove the brush from the reservoir. Apply the potassium iodide solution liberally over the cavity preparation. Continue applying the potassium iodide solution until the white precipitate clears from the preparation. Immediately following potassium iodide application, flush the cavity with water. Dry, but do not desiccate the preparation. Place a suitable matrix system prior to restoration placement. Insert Rebasc or Rebasc into the preparation up to the level of the dento-enamel junction. Prepare a resin-modified GIC bonding agent, Rebond LC. Impregnate the bond into the brush and commence condensing the glass ionomer cement. Prior to setting of the Rebasc, place a suitable composite resin, ice, into the preparation and condense the cavity to slightly overfill the preparation. Light cure the restoration for 40 seconds to enable the exothermic setting reaction of the composite resin to help set the Rebasc. Contour and polish the restoration with suitable rotary instruments. Completed restoration prior to occlusal adjustment.